it says asthma, TB, COPD, right?
Yeah.
Mhm. So a few things in this one are the same as what were in the first one, so we just kind of reviewed that yesterday. So we're going back to chest tubes. I'm thinking that if we don't get to it, maybe next week we'll do chest tubes in the lab, so that it kind of makes a little more sense than me just standing here reading this stuff to you. If you see a chest tube, you'll see what I mean by water seal and chamber and the suction chamber and things like that. All right, so there's our patient with the chest tube that we talked about yesterday. Diseases of the lung. So again, every body system is going to have different problems, issues, diseases that we're going to be covering. We learned fundamentals. We learned hypoxia. We learned oxygen. That's all fundamental stuff. This is now taking it to the patient's sick with this disease that's affecting their lungs. What or how are we going to treat them? So you can see that COPD is up here. That is a category that basically two things fall under it: chronic bronchitis and emphysema, kind of underneath of that category of COPD. What does COPD stand for? Chronic obstructive pulmonary disease. Look at those words and it should tell you, if you one by one look at the words, what it means. Chronic. So it's not an acute problem. It's a problem that a patient has for years and years and years. They develop it. Obstructive, what does that mean? Well, emphysema or chronic bronchitis is going to create some kind of inflammation, scarring, obstruction in the lungs, in the airway, that causes disease and causes the patient to have difficulty with gas exchange. That's what we talked about. Now we know what gas exchange is. Taking in oxygen, giving off carbon dioxide. Emphysema is a lung process that's so small that I can barely read it. There's a couple more slides on it. That is underneath of this category of COPD. And we'll talk about what emphysema is. Basically, these little pockets of alveoli collapse, get scarred, have a lot of inflammation. There's not a lot of gas exchange. So that's why we basically just kind of go over A and T at the beginning. What is basic anatomy for the lungs? Where is gas exchange happening? And then when these diseases happen, how does it affect that gas exchange that's not happening for the patient? Chronic bronchitis is just that. The difference between a patient though with asthma or emphysema, the patient with chronic bronchitis has a lot more secretions that build up. They have that thick cough. Many times they'll run a fever. Many times it becomes infectious, meaning that they have an infection happening there. So you can see how the asthma patient doesn't necessarily have an infection. There's something in their airway that's created that air trapping and they're not getting gas exchange, and that they can have acute attacks. Now people can have chronic asthma, yes they can. They can have it for years, but it's not really a secretion issue like bronchitis is. So we worry that ABCs with any of this stuff. Chronic bronchitis, again, many times has to be treated with antibiotics, medications that will clear up the secretions. We're always thinking about the airway for that person. In the beginning, we're going to be talking about TB a little bit. What's the difference between latent TB and active TB? What are the steps that we do to try to diagnose somebody with TB? What are our initial screening things that we're going to do for TB? Do we see TB in the United States very much? No. It's you typically in other third world countries where there's not as much of a medical model of care, not as much accessibility for care. Does it mean somebody in America can't have TB? No. But typically there's some kind of screening or something that kind of indicates maybe this person's traveled to one of these countries. But most cases of TB in the United States are pretty much minimal at this point. What's the other disease that's in there? Okay, lung cancer is obviously different types. We'll talk about that. Cystic fibrosis, that's an issue with, again, overproduction of secretions. This is one of the things with cystic fibrosis. They have an airway issue a lot of times. There's air fluid trapping in their lungs, and they have issues with repeated and constant infections, and many times don't really have that long of a lifespan most of the time, cystic fibrosis. There's your asthma patient down the bottom. What happens with asthma? Go back to what we learned in the first slide. What is happening? Air trapping, right? They're not getting good gas exchange. There's some kind of narrowing in their airway. That's asthma. Anybody in here have asthma? So you know what I'm talking about. That air exchange doesn't happen when you have those acute attacks. Right, you talk about different triggers, things that you know might trigger your asthma. We'll go over that. What are the triggers for asthma? What do we tell our patients with asthma to try to avoid so they don't have these attacks? Can we always avoid the attack? No. So then we are going to talk about what do we use when the attack is happening right now versus what do we use to try to prevent the attacks from happening. What's the last thing that's down in there? You can read what that says. Can't even read what the word is. Oh, pneumonia. Jeez, how can I forget that? Pneumonia. Can somebody have viral pneumonia? Yes. Can they have bacterial pneumonia? Yes. Most of the time, pneumonia is typically from a bacteria that has entered the lungs. So then we'll talk about what's our risk factors for pneumonia, right? The older patient, the immobile patient, the patient that just recently had a bronchoscopy tube put in, the patient who had bronchitis, but now that bronchitis has spread to their lungs, the patient that does not get cough and deep breathe after surgery, they're all of our risk factors for somebody getting pneumonia. And we'll go over each of these diseases a little bit one at a time. So TB, what is it? Is it bacteria or viral? Bacteria. Bacterial. A lot of people, I thought for years and years it was all from a virus. It's a bacterial and lung infection. So right away, if it's bacterial, what are we thinking? Well, we're going to need antibiotics, right? So somebody that has TB is typically on long-term antibiotics. Put that in the back of your head. So when you're looking for an NCLEX answer for TB, it's not going to be ampicillin for 7 days. It's going to be a combination of medications, 2 or 3 different things, and it's 6, 9, 12 months. Yes. It's a long time. And known anybody that had TB that was treated for it? Yeah. Yeah. And so it's months of treatment. And then how do we figure out that that bacterial infection is gone? 3 sputum cultures that you would need to go to the lab, and they probably would get an X-ray throughout the course of your treatment. So different doctors treat it in different ways. But basically at the end of this treatment, you go and you give a sputum culture. And what are we looking for in that sputum culture? It's called AFB, acid fast bacillus. So you're the patient with TB, you get antibiotics. The doctor should order for you one of a couple different things. Throughout the course, you're probably going to get an X-ray. What's happening with your lungs? Is the infiltrates and the bacteria in your lungs going away? Is it clearing up? According to ATI, how are we for sure going to know that your TB is gone? Go to the lab, give a sputum sample. We're checking for this bacteria in your sputum. Now, 1 time is not enough. Our Utopia ATI answer is 3 different times that you go to the lab, you spit in this cup, you get a sputum sample, your AFB culture is negative. What that now tells us is the bacteria is cleared up and you're okay. Now, what should we be teaching someone if they're active TB at home around other people? Well, you're going to probably assume that the other people have been exposed to it, right? Wear your mask. It's not going to be any different than COVID. Wear your mask. Yep.
All right, so I was kind of wrong with that case that I said. The case is that the person went out of the country. All right, it was my daughter. I took her to Jamaica when she was maybe a couple months. Came back. They tested her for TB. She tested positive. But they gave her the medication for 12 months. So they said she was fine because her lung X-ray was always normal.
Okay.
But then, you know, like a couple months ago, I always told her doctor that I wanted her to do the quantum just to make sure. So we did that and it was negative.
Okay.
So it was a case of her not having TB, but she tested positive because she got the injection in Jamaica. So that made her come up as a positive.
So the difference between latent and active. So at this point, she would be considered latent TB, LATENT. What that means is somewhere along the way, she's been exposed to that acid fast bacillus bacteria that created the TB. Active TB is, okay, my PPD is positive, or and now I did an x-ray, there's infiltrates on the x-ray, and I have symptoms. So you have the cough, the shortness of breath, hemoptysis, night sweats, fever. These are all the symptoms that we're going to talk about. So that's active. When can I spread it? Active. Like your daughter right now wouldn't be contagious, but there are some physicians who say, okay, when she came back, did she have symptoms?
She was never sick.
She was never sick. Did she
just
have a
got the
positive
shot.
PPD?
Yeah,
And it was-
I got her the shot when we were there, the whatever, what's that?
And the
The
PPD?
vaccine, no, the TB vaccine.
Okay.
It's called BCG.
The
Okay.
BCG.
Okay, so she got the vaccine. So then because of the vaccine, just like MMR and other things, now your immunity says you're positive
That's
for
what
that.
happened.
Right. But then they still treated her for 12 months?
Yeah, they
That's-
never checked to make sure it was
Yeah.
a vaccine.
So to me, that seems like a little overkill,
Yeah.
and it probably was. Because if she got the vaccine, she's gonna test positive.
Some of
So
them
then
were
if
like,
she did the x-ray and the x-ray was negative and she had no symptoms, and I'm not the doctor, so I'm not saying your doctor was wrong.
They were wrong.
Okay, well, then if you said it, I'll say it too. He was wrong, or shit, because if they didn't have active symptoms, they did not need 12 months of active treatment for TB. You know what I mean?
Yeah, it was
So-
hard.
Right,
Trying
that's
to
how,
give a
that's,
baby something like that to drink when they know the difference in taste.
yeah, for a long time, not 7 days. You're talking months and months and months. So typically, here's what we need to know about TB. It's a bacterial infection. We're gonna treat it with a combination of antibiotics, and I'll talk about what the antibiotics are. Basically, how do I spread it through the airborne particles, and what do we need to wear when the person has TB? An N95 mask. The other masks that you may see in, on NCLEX might say HEPA filter mask. Have you seen that come up?
Yes.
So you're saying, what's a HEPA filter mask? Well, it might not always say N95. And again, what I keep telling you, don't look for those one word things that you say, I saw that on the PowerPoint. What if I don't see N95? Oh my gosh, now what do I pick? HEPA filter might be what they call it. It's the same exact thing. So again, it's a bacterial infection spread from one person to another. It's droplets in the air, but the precautions that we use are airborne. The reason why, it's really tiny, small droplets that spread easily. So whenever you're going into a room where you suspect, even if you're not 100% sure that person has TB or not, airborne precautions, that's what we're always gonna pick. So the N95 mask, cover your, obviously wear that mask. Make sure that it fits around you securely so you're not exposed to that person with TB. If we then figure out that the person has shortness of breath or hemoptysis or their symptoms are from something else, can we take them off of the isolation for that? Yes, but we want to err on the side of caution if we're not sure until we get that x-ray, until we get that sputum culture back. We're going to assume that that's what they have is TB, especially if their PPD is positive, they've been out of the country, they've been possibly exposed to it. Treat that patient like they're positive until you know otherwise, right? To protect yourself. Is TB a disease that is reportable? Remember how in the
Yes.
beginning we said you have to report it?
Yes.
Yes, it is. COVID right now is a reportable disease. When you get COVID, guess what happens? Your name gets put on the list at DPH. And if I were to call, or Marika were to call, or whoever were to call, there's a list of names, because right now it's an infectious disease that's reportable, and they're trying to get tracing and contact and figure out, how many people are getting this. So TB is one of them. Your patient tests positive for TB, it's a reportable thing. You have to report it to the Division of Public Health for that patient. There are TB, I think there's one in Newark where there's like a TB clinic or something that it's called,
Hudson, Rick.
a Hudson Center or something, yeah.
Yeah.
And they will treat patients with latent TB
They
or
called
active
me because I
TB.
got
and-
a positive test.
Right.
So my state council had to report it, and then they called you, and you have to go there to do like chest X-ray.
on that.
Yeah.
Okay, so here's our things that we need to know about TB. It's highly communicable. What does that even mean? It's highly contagious. It spreads easy. That's all that means. Airborne precautions are necessary. So not contact, not droplet. If you're only gonna pick one thing going into the TB room, because NCLEX is gonna want us to pick Minimal PPE, we all want to go for gown, gloves, goggles, mask, because that's what we have, and if that's what I have at Clipstone, that's what I'm gonna use. But for TB, what is the one thing that we're gonna pick if we can do no other thing? We only have one PPE piece of equipment, our N95 mask. Everybody okay with that? Because that's what NCLEX is gonna want you to pick. Don't say, well, I'm gonna put a gown on, because what if I lean up against the table? Take the what ifs out of your head. Remember, what's my minimal amount? If I'm only gonna pick the minimal amount of what I have to have. Now, in real life, what do I do if I'm going in and I've got a gown and I've got gloves and
Everything.
I'm putting it on, right? Isn't that real life?
Yeah.
But NCLEX is a little bit different. They want us to recognize that, okay, don't always pick gloves and think, well, I'm gonna use gloves because that's the best thing to use. The mask would be the best thing for you to use for this person. So pick that, the N95 mask, because it's airborne. So this person has persistent cough. I don't have TB, I promise. But obviously people can have coughs for other things. But again, how would I know I didn't have TB? I've had PPDs done because we're required to get them here. So I don't have any indication that there is a positive PPD test. The other name for PPD is MANTOUX, MANTOUX. It's the same exact test. So if you see that on NCLEX, that's the same exact thing that you guys are learning now and will learn today and practice in the lab. MANTOUX test, giving an intradermal. Has anybody in here ever given an intradermal injection?
Yes.
So what do we know about that? Bevel up, right? You know what I mean by the bevel of the needle, the opening at the end of the needle, that where the fluid is. 15-degree angle, so you don't go in like this and shove the medication in. It's not sub-Q, it's not IM. We're not going at a 90-degree angle. 15 degrees, that's very close to the surface. Bevel up. You're making a little wheel, right? A little circle with that fluid. You guys have all had them done, almost all of you guys. And then what are we looking for? 48 hours later, we're reading, is that little wheel or that little circle red, irritated, raised? Do you have any kind of symptoms around that spot? And that's how we know you've potentially been exposed to TB. Don't pick that a positive PPD says you have TB. That's not what it indicates. It just means that you potentially have had exposure to it. So that's not going to be your diagnostic test, because a lot of us might test positive with that, but yet we don't have active TB. Everybody okay with that? Because that is a trick question kind of on NCLEX. Okay, they have positive PPD. What does that indicate? It does not indicate that they have active TB. It just means that they've been exposed to it somewhere. So now if you have that exposure, just like Tashana was saying, now what do they do with you? They make you get a chest x-ray. They possibly have you do a quantiferon test, right? These are the next steps to set. And again, what are they going to ask you? Do you have any of these symptoms? Do you have a fever at nighttime? Do you have chills? Do you have a cough? Are you coughing up blood? Do you have night sweats? Have you been losing weight? And the patient says, no, 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 no. And the chest x-ray is negative. What's the treatment going to be? Nothing. Continue to monitor the patient, right? But if the patient has a positive PPD and they have hemoptysis and a cough and night sweats and they've been losing weight, now what do you think the treatment's going to be? You have symptoms. You have symptoms of active TB. Your PPD is positive. We're going to get a chest x-ray. 100% of the time, chest x-ray is not always abnormal, depending on how sick the person is. But most of the time, you'll see some changes on the chest x-ray if the patient does actually have active TB. What's the other thing that they can do? That quantiferon test, and that would be elevated and positive. Okay, so now, how else can we diagnose it? Go back to the sputum culture that I was just talking about. And now you get a sputum culture and you're checking it for AFB. That's what it's called. That's the bacteria that's present when somebody has TB. So now we tell the patient, you need to provide a sputum sample for us. So have we seen anything in ATI yet on how to get a sputum sample?
Yeah.
We watched that video. Okay.
Yeah.
When's the best time?
Early in the morning.
First thing in the morning, take that. Do we want somebody to just spit a little bit in the cup? No, we need them to really pack up a good amount of secretion for us, right? Spitting in a cup, it's going to come back and it's going to say oral pharyngeal flora. That's what the reading will tell you. And we'd send them all the time from Christiane, taking care of a patient. You were always like, oh, gotta do this again. Because all we really got was a little bit of spit from the patient's mouth. So the better the, whatever you want to call it, the stuff they cough up, it's nasty. The nastier it looks, the more you're like, okay, I got a good sample. This is what I'm sending to the lab. Am I using a clean cup or a sterile cup to get this specimen? Sterile. Sterile. Okay, do you know what I mean by the difference between a clean cup that has a lid on it that maybe we're just getting a simple UA with, or maybe we just can put the patient's dentures in, or whatever we want to keep in there? It has to be a sterile cup. Here's the reason why. What about the bacteria that's already inside of that clean cup? So now I'm sending it to the lab. I want to make sure that what I'm sending is inside of a sterile cup and nothing else contaminated the specimen that I sent, right? It makes sense. If I'm doing a urine culture and sensitivity, what am I using? A sterile cup. So what's sterile about that cup? Is the inside of the lid sterile? Yeah. So you take it out of that plastic packaging. Do not take the lid and set it down with the lid, like the top of the lid down. Do you understand what I mean? On a table or whatever. And then stick it back on the container. Because what have you just done? You've contaminated the lid. So you got to think about what you're doing when you're getting these samples. So again, set the lid somewhere, maybe back inside that plastic you just removed, but certainly set it with the lid part down. Don't touch the inside of it with your fingers. Don't have the patient touch the inside of it. Put the lid back on, put the patient's name and label, blah, 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 and send it to the lab. So here's our cultures that we're going to get. And it would be positive for AFB on 3 consecutive positive tests. So how long do you think that might take to get 3 consecutive positive tests? What if you have a patient that, again, isn't coughing up anything, or doesn't really cooperate with you, or is confused and has dementia and doesn't have any idea what you're saying about coughing in a cup? Do you think somebody's going to wait until all 3 of those tests are back before they start antibiotics? No. We're going to err on the side of caution, right? And we're going to go ahead and start these antibiotics and almost kind of assume you got symptoms, you have a positive PPD, your chest x-ray doesn't look so good. Sure, we'll get a sputum culture on you, but we're not going to wait until all 3 of them are back, because how long is that going to take?
3 days.
3 days to get it, but then now another 2 or 3 days to get the results, right? So don't think we're going to wait for 7 days, because what's going to happen in those 7 days if we don't give antibiotics? The patient's not getting treatment. They're going to get sicker, and they're potentially going to expose every single person that walks in the room, right? So from the beginning, when we think you have a positive PPD and we know your history says, hey, I recently traveled to blah, 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 the doctor's going to say, take the antibiotics until we're 100% sure that this is definitely TB treatment. Here's our symptoms: cough, hemoptysis, positive sputum cultures, fever, night sweats. They become anorexic. They don't want to eat. They have a poor appetite. They lose weight. What's malaise mean? Just generally not feeling good. Malaise is, I'm sick with the flu and I just don't feel good at all. That's malaise. People are not going to walk up to you and say, I have malaise. They're going to say, I just don't feel good today. I haven't been feeling good for a couple of days. I feel weak. I feel tired. I just don't feel like myself. That's malaise. But we have to give it a medical term, because that's what we do in medicine, right? We make up words that we have to now memorize, right? Like urticaria for hives. Why don't we just call it hives?
Yeah.
I don't know why, but we don't. So here's malaise, and then the fatigue. So here's your signs and symptoms. This is on the respiratory test, right? These are your select all that apply, my signs and symptoms of TB. And what kind of precautions are necessary is absolutely essential that you guys recognize. It's not droplet, it's airborne. What are the 3 things that are in airborne? MTB. Measles, TB, and varicella, right? Remember that way back from September. Gosh, seems like a lifetime ago. But we can't forget that stuff as we move along here. So now we know we're in airborne. It's an infectious disease caused by Mycobacterium tuberculosis, and how it shows up is that AFB culture is positive. It's transmitted through aerosolization, airborne route, Only a small percentage of people infected with TB actually develop active TB. So there's a lot more people out there that have latent TB than active. They've been exposed, maybe like your daughter who had traveled, she got the vaccines, and that right there gave her the exposure, right? But that was a good thing. She needed that BCG vaccine to hopefully prevent her from picking it up for real from people where you were going
I
to.
take my daughter to get it.
Yeah, if you know you're gonna
She's going to
travel.
Jamaica, so she gonna
Right.
get it.
The TB bacillus can lie dormant for many years before producing the disease. So again, a physician will decide, do you need treatment, not need treatment? We're thinking maybe your daughter maybe didn't need that. Maybe the doctor felt like she was a small child and she potentially, her positive test was there. You should have realized she got the vaccine and she was going to be positive. If you get the varicella vaccine, aren't you going to have a titer that says you have had varicella? That's what the vaccine does. That's the purpose of the vaccines that we get: MMR, varicella, Hep B. If you get Hep B and you get the 3 series, what were we telling you all summer? We're looking for your titer that says you have immunity to hepatitis B. Can some people get these shots and not develop immunity? Yes. And that's why you go back and you get a booster, the second shot, so that you do have immunity. So that's how vaccines work. That's why we're saying, we're coming back to you now saying, hey, it looks like you got 1 MMR, but you didn't get the second one. Or your titer doesn't show that you have immunity to it. So show me something that says, okay, you had varicella as a child. Now you're not going to get varicella again. So it's the same thing. It can lie dormant and can produce disease later on. So here's our symptoms: cough that lasts 3 weeks or more. So it's not the person that has the cold that lasts for a couple of days. Coughing up blood, that's hemoptysis. We got to know what that word is. Again, I don't know why we don't just say coughing up blood, but we don't. We come up with a word for it: hemoptysis. Chest pain, pain with breathing or coughing, weight loss, fatigue, fever, night sweats, chills, loss of appetite. They're all there again. All kind of the picture of the person that actually has TB going on. These are their symptoms. So here's our risk factors. This is an important slide for you to know what makes us more at risk for getting TB. And like you were just saying, if you know you're going to travel to a country that may not have the best water source or may not have all the care in the hospitals that they need to treat people and kind of eradicate this disease a little more, there's your risk, right? Traveling to the places where it's more likely to pick up. So frequent and close contact with an untreated individual. So there's your person at home that has TB that you're living with. So what is our teaching for people that have TB at home? Many times the physician will say, hey, you live with your wife, your spouse, your brother, your children. It's probably a good idea for us to treat everybody in the house. And a lot of times doctors will do that because they're going to assume that somewhere along the way you had your mask off and this person people living with you could potentially get this disease. So here's another risk factor: lower socioeconomic status and homeless. So that's just people out on the street that don't have good basic care, don't have a roof over their head, don't have a place they're potentially exposed to other people who are not receiving good physical, everyday ADL care and able to shower and bathe and get rid of germs and not be potentially exposed to extra things that some of those people are. Immunocompromised patients. So here's your patient with HIV. Anybody in this category right here are your immunocompromised people. What else can immunocompromised people? Well, again, a recent transplant of some type, liver, kidney, any kind of recent organ that was transplanted into you, chemotherapy. Immunocompromised people are Lyme's, lupus is an autoimmune disease. They're immunocompromised. So anything that rheumatoid arthritis, autoimmune disease, immunocompromised. So they all go in this category. HIV is not as prevalent as it was back in the 80s and 90s, right? You heard of so many more people having HIV and getting sick. Now there's a lot of different antivirals out there that basically contain this virus. Does everybody understand what I mean? We're not hearing about HIV like we were years and years ago. Is it still out there? Yes. If somebody has it, are they more likely, more susceptible to other things? Yes, that has not changed. But what has changed is more medications have been developed to try to keep that virus under control. So HIV goes into immunocompromised. Somebody getting chemotherapy, why does that make them immunocompromised? What is it? What does chemotherapy do to all your blood cells, all your tissues? That's why you lose your hair. That's why you get sick to your stomach. That's why you have difficulty breathing. Chemotherapy does not just attack the cancer cells, it attacks everything. So your red blood cells go down, your white blood cells go down, your skin cells get attacked. So this is the reason why people lose their hair. They side effects of the chemo. The chemo does this to the patient. It's necessary to kill the cancer, but we got to put 2 and 2 together and say, hey, the patient's red blood cell count's going to be down, their white blood cell count's going to be down, higher risk of infection. So they're more risk or more likely to become sick if they were exposed to this bacteria. That's what immunocompromised means, is that your immune system is compromised by something or some kind of disease. So there's your chemotherapy patient. Somebody with kidney disease, we're always very careful when they get hooked to that dialysis machine. I wish we could get out to dialysis this year. You would see what I mean. They are very careful that all the equipment is totally sterile every single time. It takes a lot more time, a lot more effort, but you're not going to hook somebody up to a dialysis machine, because think about it. You're circulating the blood in their body. Everything has to be sterile, not just clean, right? It has to be a sterile procedure because they're likely to be immunocompromised. They're getting dialysis 3 times a week. Their kidneys aren't filtering. Their kidneys aren't working well. We have to be very careful with infection for those patients. Your diabetic patient is a risk factor. Crohn's disease, again, is another autoimmune disease that makes people, we sometimes forget this one, it's a bowel disorder, but it makes people more likely to develop and pick up other diseases. So we have to be careful that we are paying attention to the Crohn's disease patient when they have signs of infection in other places. We're aware of that and alert to that. Poorly ventilated, crowded environments. So there's your people that live in prisons and long-term care facilities. That's who we're taking care of, right? Not the prison people, but the long-term care facilities. Now, I have had several nurses in the last couple of years go work in the prison system. There are good LPN jobs in the prison system. That might be a place that somebody might like. But what you got to recognize is all those people are living in crowded conditions. So I was just listening to something last night, actually, on the news talking about prisoners in California, that they're proposing that they release 50% of the prisoners in this prison in California. I forget what the county was, but the sheriff came on and he said, we have already released all the minor offense people. And now what they're asking them to release is the murderers and the child. And this is California. And I'm like, I'm glad I don't live there, because they're all contracting COVID. And they all live there, but I tell myself, wait, where's the risk versus the benefit here? You're gonna let all these murderer people out on the street because they have COVID. Well, what would you do if you were a murderer in there? I'd probably be going next to the person that had COVID, right? I want to get out of here. So these people have been in there for years and they're releasing them now. They're saying 50% of them should be released so that they can socially distance in the prison. I'm like,
in New Jersey too.
Yeah, they did in Delaware too. And again, it's like a whole can of worms, because some people probably think, well, we got to be fair to the prisoners. Me, I say, wait, they're in the prison for a reason. And I personally think, I can't help it that they can't social distance, but they're in there. I don't want the prisoner out on the street at Wawa tomorrow, right? I mean, that's where are they going? They're going to be out and they're going to be on the street. So anyway, I was just listening to that. What?
Me and Cynthia, we listen to murder cases.
Yeah.
So it's kind of like now the government is giving us the option of which way we want to die.
Yeah, I mean, I don't know. It's so crazy. Would you have ever thought that the government would be saying, release 50% of your murderers out because so that people don't get COVID in the prison?
They don't take them back. They just let them.
They just let them go. No, they let them out. They don't take them back. No, they're just releasing them so that they have space to social distance.
That's scary though.
Yes, that's scary.
I
don't know how they're figuring it out. But basically the sheriff was saying that the people that we've already released were minor offenses. We no longer have any minor offense people. How are we going to release them into society? because of COVID, so it's like, wait, we're not looking at the long-term consequences of this, like, what are these people gonna do? So anyway, it was just on the news last night, and it made me think about it. I was just like, man, COVID has just literally changed the entire world. So here, they can get TB, but they're not getting out of prison if they get TB. They're just being isolated from other people. So here's your risk factors: being in a crowded environment. What about living in a dorm at college? Wouldn't that be a risk factor if somebody there had TB?
Yes.
So always think about like what are the living conditions of these people? Here's advanced age. Anybody older adult, that's what ATI calls it, is always going to be a risk for everything. Recent travel outside of the United States, where TB is more active, substance use, healthcare occupation that makes us at risk because of our exposure and high risk activities that we do. One of those high risk activities: suctioning patients, being around them, being in close contact. Aren't we in close contact now and high risk for COVID? Don't you hear that the vaccines are going to healthcare workers first? Thank the Lord, right? Because they should be.
Yep.
Yesterday on the news, this was a good thing I saw. A nurse that I work with at Kent was the first person down in Dover to get the vaccine yesterday. And I was like, wait, I know her. Yeah. So here, these are your high risk people, right? This is us. We're high risk because of our potential exposure to this disease, if the patient has it, right? Wouldn't it make more sense? We're more high risk than somebody that's, not around it. So we need to you guys want to take a break? Yeah, let's take a break for about 10 minutes and we'll come back. Take a break.
Like, let the murderers out and just.
I'm sure they're not letting serial killers out. I mean, it's a lot of people. It's a lot of people that probably has murder charge, but you don't understand the situation. You know what I mean? I'm pretty sure. It's like
That's all you
that's
said when they left the brothers out. They're gonna have a flashback. It's just those cute people.
I'm pretty sure they're not letting them fight people out.
No, it's just like that lady. She was right about the Wawa. Every time on the Wawa,
They don't mean to do what the Wawa's murder.
no,
I'm pretty sure they're not letting the go in
No, that's a one-time offenders.
That's what I'm talking about. But to be honest, I know she didn't actually let some people off. Somebody very close to my family was locked up in Jersey. She was at the wrong place at the wrong time, but they gave her 5 years. She caught COVID and they locked her in a room by herself. And the COs were scared to help her, and she died. She just died. She died. So yes, if you can't help them in there, then you have to let some people out that hasn't been like, because so yeah, that's not my thing. But I'm pretty sure they're not letting a serial killer out of jail for
I mean, like,
COVID.
oh my gosh, I totally heard about you. I'm such a big fan.
What? The person?
When the serial killers come out.
Like Ted Bundy.
No,
They I know, if he was alive, I would have to say, he was fine. Yeah, he was.
Yes, he was. Yes, he did. In the head, but she was.
Yeah, that's why he got the I know.
He was
Yeah, but she was right too.
My head was cute. Yes, he was.
Anyway.
How did he get to kill all those women if he wasn't big before?
Have you seen like the actual ones?
Yes.
Yes.
No.
I did. You know who I'm worried about it now? Oh my gosh, I just listened to his story. And he was like 6'9" and the bomb? No.
Not Charles Manson.
No.
He's still alive.
It was the one where he killed his grandma. And then he killed his mom. The one where I'm trying to I sent it to I was watching because everyone was and we were just talking about Girl, I'm glad he's still there.
So how come he's still alive?
Girl, he belongs.
And he did all of that.
No, his girl was just, they were.
I thought they would have gave him that IV for vaccine.
No, definitely.
It's not you, Pat, they get treatment.
One of them was Pat.
Okay.
They,
They have it, but it's just like, you have to be specific. You get it.
yeah. But I said, I can't help it. I would be
And they tell me,
You
I like watching those stuff too.
Yes, I'm okay with it.
I do like watching it.
And he was just a really big guy. He was like 6'9", and he was just, his IQ was like
0.
No, he was really smart.
So what? You know what? They're
He was
crazy
too,
ones.
he was too smart.
Okay, yeah.
Very smart.
This is on the Facebook. So you type in, I am, and then say you.
I like to watch it.
It's like the kid, they have this, center, so she goes, hey, it's fine, so you need to stop it, I'm traveling. And he knows she, like, I don't know, like, I don't know. They have seen you.
What did she say?
No, it's just, I don't know, he was like, yeah, just come with me, I'll try for this, they said, come.
Not the truck.
He goes, you can go say like, used to be a cup.
I don't know.
And you guys are like, no, she on the phone. No, she didn't. She. Yeah, I'm there. Like, the first time I heard, I remember the girls got very upset. You got it all. It's like another one.
No, we
It was just so many people watched that. They were like, I don't know. It was like,
Y'all watch it.
and it was another one.
I see you there. We don't have a truck.
Hold on.
I just heard, I heard another story. There was this girl. I don't know why, man. I gotta go there and she died. They never knew because I'm not.
Did you hear about the story where the kids were living in the house and the mother's dead body was in that house for like 3 years? This year. Yeah. Big ass kid, like, in the house. And the mom was upstairs, but they said that their IQ was like, she was down to bones in the leg of Lund.
I don't like the all the first aid. They post their stories on how their child died. I don't like that. I wish it was an extra where you could like, I don't want those type of things.
But it's like all watching it.
Oh my God. I just watched it.
I'm serious, that's the way I see it. Just don't be commenting on my picture and page. Okay? When I started.
This guy says, more
Don't say nothing, don't say, wow.
We could do another order like in January altogether. Remind me when we come back. I don't want to deal with it right now before Christmas and stuff, but when we come back, we can order and make another order.
Miss Anderson? Miss Anderson?
I wish I had like matching pants.
Miss Anderson, can you hear us?
Uh-huh.
Mackenzie's calling you.
Calling me on my phone?
No, on here.
Hey, what's up?
Rhonda. Thanks, Rhonda. The people that ordered extra scrubs, when, do you know when we'll get
Hold
them?
on. Go ahead, Mackenzie.
The people that ordered extra scrubs, do you know when we're gonna get them?
Miss Sylvia would know. I think she's dropping them off Thursday. I think she sent me an email.
Okay, thank you.
Uh-huh, yep. I think she said Thursday.
Oh, Miss Anderson, did you ever approve me? Did you
to record.
Do I have to approve you on here?
Yeah, it says ask your instructor to give permission.
Oh, I don't know. I just said, yeah.
Yeah, I know.
I don't know.
You was on the roll, so I was like, I'm just waiting till very long.
I don't know how to do it.
I don't know how to do that either. I don't
Sam?
think there's an option going on.
Sam, do you know how to tell me how
You know how to do
to?
that?
Security,
I don't know. I thought it would have given you a notification or something, but I guess not.
no.
Oh,
What is it under?
your birthday.
I'm under security, you would think it'd be under there.
December? So we 20.
Oh, man.
I know, right? What is close?
Which one?
30.
Oh, here, yeah, okay.
You nailed it?
Allowed to record, yep.
Post allowed
So I had to-
record.
Yeah, so I had to do it under your name.
Am I recording now?
You should be. Try it.
Miss Anderson,
Yeah.
this is Sharonda. Can you do mine? Because I'm running out of space on my phone.
Sharonda, let me find you. Hold on. Sharonda Moore,
Yeah, it says I'm recording now.
Yeah.
allowed to record. Yep.
And then she has to push the record button.
And then you have to push the record button, Kentrell said.
I'm recording. Can you approve me?
At the top left.
I'm Sharonda Pierce.
Yes, I got you. Sharonda Pierce, I know who you are. I allowed you to record.
Thank you.
Mhm. Is it working?
I'm standing with you. I'm monitoring. There's no kids touching this boy.
I'm waiting.
Okay? I see that monitor over the Instagram. I'm like, okay. This is future. Speaking of something, all right.
Did you get my request, Miss Anderson?
Huh?
I said, did you get my request so I could record lecture?
Yep, I'll go in there. Yep. Okay, you should be good.
Elder abuse. I saw Regina Carter, like, she had posted a picture on Instagram when she turned over and I stole it. I'm like, this gonna be my birthday.
All right, everybody ready? Let's keep moving. All right, so here's our signs and symptoms of TB. This is gonna be on the exam. I'll tell you right now, it's on there, select all and apply. You should know it. I promise you, NCLEX will ask someone about TB. It's a disease that's always been there, always will be. They want to know that you understand the difference between active and latent. How do we diagnose someone? What are the signs and symptoms? What is our treatment going to be? So here's your patient. Here's our risk factor. So here's our person with TB, and I would put active on the top of this one, so you understand the difference, right? So this is your active person with TB. They usually, and again, look at this, whenever you get to NCLEX, don't pick an answer that has the word always 100% of the time, because there's nothing that's 100% of the time. So be careful with that word. So usually has a skin test or a blood test indicating a TB infection. So what is that? That's our PPD. That's our Mantoux test. That's an intradermal in your arm that indicates that they have been exposed to TB. They may have an abnormal chest X-ray. Look how that says may. It doesn't mean that every single person with active TB has a chest X-ray that's going to show up. They may. Or positive sputum for AFB. They have active TB in his or her body right now. So are they contagious? Yes, they are. they may spread TB to others. Look how they, again, usually feel sick, usually have symptoms, and we just went over what the symptoms are. So you can see how not everybody 100% of the time has every single one of these things. We have to figure out, what do they look like? What are their symptoms? What's their x-ray look like? Do they have a positive PPD? We start there. If you already have known that you've had a positive PPD in the past, what then do you go get instead of that positive PPD? A quantiferon, right? A chest x-ray. Because once you have that PPD that's shows you've been exposed, many times that PPD is always going to be positive.
One time I got it, my kid, like, it raised really high, like
Mhm.
20 mm, the nurse said. She was like,
20
whoa.
millimeters, yeah.
Yeah.
So what that means is somewhere in the past, you've been exposed to TB. So now we have to do these other things to figure out, is it active or is it latent, meaning it's kind of asleep right now. It's there, it's in your system, but you're not gonna infect someone. So here's our good way, this one and this slide here, these two, to kind of recognize, does the person have active TB versus latent TB? Here's our active TB person. So they can spread TB to others, and they need treatment. They need the combination of antibiotics to get rid of this active TB that's in their body. That makes sense, right? So don't get confused when you see stuff on NCLEX talking about the patient has a positive PPD. What would this indicate? Don't pick the patient has active TB. It doesn't indicate that. It indicates that they've been exposed to it. What's going to indicate it is the symptoms, the x-ray, the sputum culture. Everybody with me? Because this is an NCLEX 101. They love asking these kind of questions. So here's your latent person. What do they have? They may have that positive skin test, just like you're saying that you have, Toshana. What do you have? A normal chest x-ray, a normal sputum test. What does this mean? They have TB bacteria in their body, somewhere they've been exposed to it. Can they spread it to other people? No. And again, needs treatment for latent TB infection to prevent it. However, if exposed by and infected by another person, prevention treatment may not be an option. So sometimes what a doctor will do is, if you're in this category of latent, you have the potential, they decide, okay, what are your living conditions? Are you around immunocompromised people? Have you had any symptoms, even if the symptoms were a month ago? Again, what are we doing? Most of the time, just watching the person, monitoring the person. Sometimes a doctor, like you were saying with your daughter, might decide, okay, you had a positive indication that you were exposed. Okay, the safest thing would be to treat you. And I have heard doctors doing that. Even though the patient doesn't have active symptoms, they sometimes will choose to treat the patient. So just be aware that there's a lot of different variables with TB. One thing we know for sure, positive PPD, positive x-ray, and symptoms, you're getting treatment. Sometimes even with latent, depending on when the patient was, let's just say you recently traveled and now you were just recently exposed, why would we wait for your symptoms to develop? Maybe we'll treat you right now, right? Is this making sense? So it just depends on the situation and the patient. Most of the time, almost all the time, a person with latent TB will just be monitored and watched, and it just indicates somewhere along the way you were exposed. As long as you don't have any symptoms, you're not contagious to other people. We're just going to watch things that are going on. So here's our meds that we're going to pick for TB. One of the first ones that is picked is called INH. The way that you say that is isoniazid. It's an antibiotic. Another one is called rifampin. Streptomycin is an antibiotic. Remember, it's in the mycin category. And this other one that I don't even know how to pronounce. So here, what you need to recognize, you're always going to see INH. Rifampin is one that's used a lot. One thing about rifampin, when patients take it, it makes their urine turn orange. Did you see that somewhere?
Yeah.
Oh, well, then I'm not telling you anything. I already know.
Her feet turned orange, so I know that was.
Oh, okay.
Yeah.
So Write this down, because this is an NCLEX thing that they like to ask us. What would we educate our patient about if we started them on rifampin? We tell the person, your urine is going to turn orange. Wouldn't you want to know that? Right? If today I started and tomorrow I'm peeing orange, wouldn't I be like, oh my God, what's happening to me? So you gotta tell the person. Okay, there it is. So rifampin turns your, is that a reason to stop the medication? No, it's expected. It's expected. So INH and rifampin are the two that are used the most, but it's gonna be a combination of antibiotics. And again, depending on the patient, it could be 6 months, it could be 9 months, it could be all the way up to 12 months. And it's hard for the patient to stay consistent with this because it's dosages of these meds 2 and 3 times a day, right? Remember, Alicia, wasn't that what, it's hard. It's hard to stay active with it. We have a hard time taking antibiotics for 7 or 10 days. We say, oh, I'm feeling better, I'm gonna stop. It's a pain in the butt, it's making me feel sick, I got diarrhea, I don't wanna take it anymore.
Like my mom, she had
Right.
an ear infection and she get an antibiotic and I have to call her every day.
Yeah, to make sure she
Remember to
takes
take it.
Imagine this for 12 months. This is a long time. So here's what we do with it. Take it on an empty stomach at the same time every day. But one thing we have to be careful of with these meds, they affect our liver. They can be hepatotoxic. Hepato means liver, right? We know what that means. So whenever somebody is taking meds for TB, put this together in your mind, we're always going to be checking their liver function because it affects our liver. It can damage our liver. So then we say, okay, let's get baseline labs on you. What are we getting? AST, ALT, ALP or ALK phos. Go back to what we know is liver. If the patient's already elevated or been a drinker or have cirrhosis or have hepatitis in the past, we gotta maybe pick streptomycin or something else because that INH and rifampin are the two that we use a lot and they affect our liver. So we would have to be very careful and monitor liver values the entire time you're on this med. So in addition to taking the meds, now every month you gotta go get your labs checked, right? This is the picture of the person with getting TB medication. So remember, the liver has to be checked. We're taking it for a long time. Take it on an empty stomach the same time every day. So you stay consistent with the levels that you're getting in your system to treat this. So again, combination therapy is needed because the bacteria is so strong and resistant to antibiotics. So up to 4 medications are taken at a time. That's a lot. That's a lot of different antibiotics. You don't just take one for 7 days, it won't go away. So INH, this is the name for INH. This is on niacinamide, I would say, rifampin. According to clients, the urine and other secretions will turn orange. Let's pretend like we're gonna say this the right way. Pyrazinamide, maybe, who knows?
Yeah.
Streptomycin is another one. And Ethambutol, I've given that before. This med should not be given to children under 13 years of age. Streptomycin, only given when the other combos have failed. What do we say about myosin drugs? What do they affect? What body part do myosin drugs affect? Your ears. Ototoxic. Do you remember us talking about myosin drugs being ototoxic? What's that mean? That affects our hearing, our balance. So now look, we don't want to use those unless if we can use the other things. Only given when the combos have failed, they can affect our hearing. Drink a lot of water with streptomycin. And remember what you're telling your patient. Put this in your category of meds. Erythromycin, gentamicin, streptomycin, vancomycin. You see how they all end in MYCIN? They affect our ears. Is it okay that our patient all of a sudden started on streptomycin and now they tell us, I feel like I can't hear as well, or I have ringing in my ears, or I feel like my balance is off? What do you think we would do? Stop that medication. So that's called ototoxicity, meaning oto meaning ears. They can potentially affect our hearing, and it could be lifetime. You remember me telling you that my husband had gentamicin for weeks, and now he has tinnitus ringing in his ears forever since then, since age 12. Since he got these long-term antibiotics.
Still?
What's that?
You said still?
Yeah, still. Yeah, just last night he said to me, do you hear any crickets? I said, I'm not hearing any crickets. I'm having a hard time falling asleep because my ears are ringing crazy.
They heard it's really bad with COVID.
Yeah.
Because I had it in, first I had it in one ear, and then it went to the other ear.
Okay.
And it was just like, well, for me, it sounded like the ocean,
Mhm.
constantly, all day, every day.
So since age 12, he was on a go-kart, he ran into a fence, he had a bad staph infection, he broke his leg, it was an open fracture. He was in AI for 6 months, and they gave him all kinds of mycin drugs. Gentamicin is what he got a lot of. And he did not know any better, he was a younger kid, and he didn't know that he was supposed to report ringing in his ears or crickets. And so now he's 55 and he still has it. And he's been to every ear specialist, Philly, Baltimore, nobody can fix it. So from this mycin drug that he got for the, and he didn't know to report it. So by the time he got older and said, wait, this isn't how it's supposed to be, it was too late. It had already damaged it inside his ear. So mycin, remember, they're in the category ototoxic. Advise the client not to drink alcohol while taking any of these meds. Well, again, we're always going to pick that. But remember, how is alcohol processed? Through our liver. Through our liver. So if we already have meds that we're on that affect our liver, even if we drink a little bit of alcohol, aren't we now double dosing our liver? Right? So no alcohol at all for these patients because their liver is already possibly affected from these drugs. So here's our teaching. Reinforce teaching the client and the family that TB is often treated in the home setting. Why? Why do we want to treat this patient at home with long-term antibiotics? So we don't risk getting everybody in the hospital or acute care facility affected. So yes, you're sick, but you're going to stay at home and be sick, right? Exposed family members should be tested because you live with the patient, just like now with COVID. If you know somebody at your house is positive, what are you going to probably do? Check on the other people and get them tested too, right? Because we all live in the same spot. Reinforce teaching to the client and family to continue meds for 6 to 12 months. Emphasize the failure to take this can make the bacteria be resistant and stay there and not go away. Reinforce instructions to continue with follow-up care for up to a year. That's a long time for treatment. Inform the client that sputum samples are needed every 2 to 4 weeks to monitor for effectiveness. What are we checking for? Well, we're looking for that AFB in their sputum. So while they're getting the course of this treatment, these patients will be going maybe once a month to go get a sputum culture. And if one came back negative, what would we do again? The next month, get another negative one. Look what we have to do. Clients are no longer considered infectious after 3 sputum cultures. That's a key point. So once they've been 3 times and AFB is negative, now we say, okay, you can stop your antibiotics. If along the course of the treatment, they're positive, what do you think they're going to do? Continue the antibiotics until the bacteria is fully gone. Obviously, encourage proper hand hygiene. Reinforce client instructions to cover their mouth and nose when coughing or sneezing. Reinforce client instructions that contaminated tissues should be disposed of in plastic bags. Have you ever walked into a patient's room where they have their tissues, their napkins, their things that they have blown their nose with, and where do they put them? On their bedside table? Don't pick them up. Put some gloves on. But these people in particular, we're telling them, give them a plastic bag to put their tissues or napkins in. Tell them to put it right in the trash that's contained, and so everybody else coming along is not touching it and potentially getting exposed to it. I think now about people that used to use handkerchiefs. You don't see them as much now. Nope. But remember before, older men would always have handkerchiefs in their pocket, and I think, oh gosh, if you think about that now, put it in your pocket, put it back in your pocket, right? Isn't that what people did? Yeah. And they thought that they were doing the right thing, but it's like, oh gosh. So these people, tell them, put their tissues in plastic bags, contained. Give them a bag that's sealed that they can put their tissues in and throw it away. Don't let them sit it on the bedside table or put it on their lunch tray that now gets carried out of the room. Reinforce to the client who has active TB to wear an N95 or HEPA when in public places. They have to wear it too, and then it's a reportable disease, so we have to let the state know. We have a patient here in our facility that has active TB. We have to report it. This slide is important because this is your select all and apply What do I teach my patient that has TB about their napkins or tissues, how long they have to go to care for, when do they get sputum cultures, make sure you wash your hands, blah, 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 blah. And it's basically saying the same thing. N95. If the patient needs to go out of the house, a regular surgical mask is not enough for this person. They need an N95 too if they need to go to a doctor's appointment or wherever they need to go. Would we encourage this person to travel to Christiana Mall? Heck no. It's amazing to me. I had to pick up something the other day. I didn't even go in the mall. But I'm thinking, okay, we all can't go to church. We can't go here or there. But literally there was thousands of people at the mall. There was not a parking spot. I wasn't going in the mall. What was I going there for? Oh, I had to pick up something at Dick's Sporting Goods for my son for football. And I was like, I don't even want to go in this store. But the mall was jam-packed with people. And I'm like, you would never know COVID was happening. But yet we all can't have like our own family to come over for Christmas. Like it makes no sense to me. But anyway, that's a whole nother can of worms.
Yeah.
But this person is not a good person to travel to the mall. Why not? Even if they have their mask on, who are they potentially exposing? Thousands of people at the mall. So if you're in the hospital, N95 for them is best. At the very least, a surgical mask, but that's not the best option. The HEPA filter, the N95 is best. Transport the patient the shortest and least busy route. What does that mean? What if you're a patient that has TB and we got to take them down for a CAT scan of their chest because they're getting worse? If you can, if at all possible, and your answer says portable X-ray in the room, pick that. CAT scan, we can't bring the CAT scan machine to your room, right? It's not portable. So now we take the patient with the mask on in the back hallway, not around all the visitors that are coming through the hall, basically. And that is really what you do in real life. Try to take them on the route that's not going to be as many people. There we are, put your tissues in a disposable bag, have them drink, test the family member for TB. It's often treated in the home. We already talked about that. So there's your VAN2 test. Same thing as a PPD. It's the same exact thing. It's just the brand of test that it's called, so it means the same thing. How do we know it's positive?
Great.
If we did a VAN2 test.
More than
Great,
10
and red.
More than what? More than a 10 millimeter increase in size, and we measure it. We measure it. If the patient is immunocompromised, like HIV and chemo, it's 5, right? Did ATI tell us that?
Yes.
Yeah.
It's in the book.
Okay, good. Okay, so more than 10 for everyday people, more than 5 millimeters for an immunocompromised says to me, wait, this patient's high risk. It already grew by 5 millimeters. I better do a chest X-ray, a sputum culture. I better consider, does this patient have symptoms, right? Because they already have risk factors to start with. They're going to get sicker quicker. So here's our test. That's what the VAN2 test is. We inject it with the bevel up. Positive test just indicates we have exposure. We look at it 48 to 72 hours. You guys all did this, or you did the quantiferin, or you got an X-ray. What we're looking for is, do we have an indication that that spot where we put that little bit of fluid in is raised, and that's called induration, is elevated, is red, is raised, or some kind of indication to us that it's a positive test. If we're not sure, and now you've had exposure and your PPD is positive, now look what we can do: quantiferin test or the chest X-ray. So 10 is for the normal person. Greater than 10 indicates positive exposure. Greater than 5 for somebody that is immunocompromised, like HIV, Crohn's, cancer, kidney disease, whatever it is. So here's our positive findings. Greater than 10 residents, long-term care, IV drug abusers. Basically, greater than 10 is what we should be going by. Greater than 5 is our patients down here. Most of the time, they don't wait for it to be greater than 15. Usually 10 is the indication for ATI. Isn't that what ATI tells us, greater than 10? Yes? Isn't that what's in the book?
Yes.
Greater than 10, and then greater than 5 for high-risk people. And we read it 48 to 72 hours later. What if we had it injected and we didn't read it for 7 days? Is that a good test?
No, you gotta do it again.
Gotta do it again. Gotta do it again. Every positive PPD, this is a key point, if you have a positive PPD, meaning it's greater than 10 or greater than 5, has to be, you now need an X-ray. Immediately, the person would go for a chest X-ray. That's our next step. Okay, here's our sputum. We talked about getting a sputum sample for this person. Diagnosing respiratory diseases. What do we want to do? Can they drink a little bit of water before they do the sputum? Yes, that's okay. To kind of moisten their mouth so they can actually cough up a secretion. Only water only. Tell the patient, take a couple deep breaths, cough and deep breathe before they spit. Otherwise, all you're getting is spit from their mouth. You want something that you can hopefully get from their lungs and they actually cough up something.
Sounds like a COVID.
Yeah, provide oral hygiene after the test, wash their mouth. Again, these are things that, we think, oh, well, we'll forget to do this. A lot of times you do. Make sure you label the specimen correctly and send it to the lab. So here's our sputum cultures. A couple key points about sputum. Best, first thing in the morning. That seems to be like, yourself if you're sick. When you wake up, don't you have a lot more congestion usually, or you're able to get a better sample up without being gross about it, but this is the best time to get it. Collect ASAP. Try not to contaminate with spit or sinus drainage. Here's a key point about getting sputum cultures. What do we want to do? Get them before you start the antibiotics. We've been saying that from the beginning, right? So if at all possible, get the patient to cough into that cup, that sterile cup, and then begin the antibiotics. Do you have to wait for the results to come back before you begin antibiotics? No. Go ahead and start them, but you want to get the sputum first so that the antibiotic does not potentially affect the results that you get. So again, if your client's on an antibiotic already, this is what we really did in real life. Put on the label specimen what they're already taking. So now when the lab runs it, they kind of run it differently, knowing, okay, the patient has already been on vancomycin for 7 days. And we would write that. Vancomycin treatment already initiated, or sometimes 7 days or whatever. And then again, label accurately, get to the lab as soon as possible. So here it is. Clean your mouth a little bit with a little bit of water, breathe in and out 3 times, cough into this cup for me. Don't touch the inside of the cup, don't touch the inside of the lid. And now we send it to the lab. So there's our symptoms. We already talked about this. This is what the person looks like with TB. Chronic cough, usually greater than 3 weeks. But again, don't all get trapped into, well, it's only been 2 weeks and 4 days. They can't have TB. Yes, they can. We're just looking at the overall picture of the patient. Night sweats. Later on is typically when you see the hemoptysis. And now we get treatment 6 to 12 months. Many times they're kept in isolation, they're kept at home, treated at home. Here's our diagnostic test that we just talked about. And so this is just showing you a phase of how we use antibiotics. Please don't study these slides. You're not the one prescribing them, so you're not going to be the one saying, wait, I need to expect this for 4 days or 5 days. But look, this is 8 weeks. 8 weeks, this one might be 8 more, then they get a sputum, and then they might do 8 more weeks. It's months and months of treatment. And in between, we're getting sputum cultures to see how things are going. So there's your meds that we're using. We talked about using it for months. Latent TB, again, they have it in their body. They may not feel sick. Again, depending on their exposure, sometimes they're sometimes prescribed treatment to prevent them from developing TB disease. And that would be a physician's decision. How recently were you exposed? Oh, I just came back from wherever. I'm not sick yet, but I know I was exposed to it there. Okay, well, we're going to go ahead and treat you anyway. So we're not waiting for you to develop the active disease. Again, it's going to be patient specific on what's happening. But look, we're using the same meds, and it's a combination, 3 or 4 different meds that we use. Again, look how these meds are dosed. Like, you're not going to be the one dosing them, but I do want you to realize that this one might be 3 months, and look at this one's 9 months. And then you take it daily. This one's daily, same time every day. Take on an empty stomach. And then there's a maximum and a minimum number of doses that these patients would get. And this is just talking about latent versus active. Everybody okay with what the difference between latent and active is? That's an important part of TB. Medications are what we're going to give. It's going to be long-term treatment. It's bacterial, so don't say it's viral and pick an antiviral. It's a bacterial infection. You need antibiotics. Nursing education, tell them to wear a mask. What's the room that the patient needs to be in if they have TB? It's called a negative pressure room. Pick that, negative airflow. That's what they have to be in. If not, at home. Send them home. If you don't have them, can the patient travel? No. This patient should not be getting in an airplane, right, and traveling across the country with active TB. They shouldn't be traveling anywhere because they're going to potentially expose everybody. All right, any other questions about TB? Yes, no? Everybody good? Let me see how long this asthma one is. It's long. It's long. It is long. All right, so we're just gonna talk about asthma for a little bit. I promise we're not gonna get through all of this. So a couple of people said in here they have asthma. What's the difference? Well, asthma is not TB. It's obviously a different thing. It's a long-term lung disease. It is chronic most of the time. Can kids have asthma and outgrow it? Yes, they can. Yes. When do we typically see asthma? Most of the time in childhood age, it kicks in. But again, somebody can develop it later. I have developed asthma later in life. For telling me I'm allergic to dogs and dust. Do I have an inhaler? Yes. Did I have one when I was younger? No. So it's a different disease. People can get it at different times. Many times it manifests itself in childhood age. It's a long-term lung disease. What happens? Airways become narrow. Asthma causes chest tightness, shortness of breath, coughing, and wheezing. Look at that end of the airway. See how it's supposed to normally be open? That's where the gas exchange is happening. Look at this asthma airway over here. So the airway itself becomes tight, inflamed, narrowed. That gas exchange is unable to happen. What is the key thing we're going to hear when the patient has asthma? Wheezing. When do we typically hear it? Most of the time on expiration. But again, some people can have inspiratory wheezing, some people can have expiratory wheezing, some people can have both. Can someone die from asthma? I'm not trying to scare anybody in here, but yes, they can. When is it an issue? Anybody heard of status asthmaticus? It's just like status epilepticus. Status asthmaticus is the asthma attack is lasting near that 5-minute mark. What is happening for that airway? If I can't control it with my albuterol or my neb treatment in those first couple minutes, how long can I go without oxygen, right? That's basically the point. So as status asthmaticus is a life-threatening emergency, you have to get treatment. You would be calling 911. Can I give a neb treatment one after the other? Yes, I can, but that's what I need to open the airway. What's the first thing I'm gonna pick for my patient that needs asthma right now? Albuterol. Pick that in your answer on NCLEX. Don't pick anything else that's just preventative. Well, I do know that I have a friend that uses this. Don't think that. Albuterol is your choice for the patient with asthma right now because it's a bronchodilator. It opens our lungs. It helps us breathe. What are our triggers? Here they are. This is a question on your test. This could be a question in ATI and on NCLEX. What's our asthma triggers? Smoke is always going to be one. Being exposed to it or you being the smoker. Not a good plan if you're an asthma patient. What about stress, exercise, cold air? Okay, right now, yes, I know I have asthma. I have this cough. When I go outside and it's cold, what happens to me? I'm even worse outside in the cold extreme temperature, right? So smoking, cold air, stress. You guys stressing me in the morning when I'm trying to get a shower and everybody's texting and calling me. I'm just kidding. I didn't have an asthma attack this morning. Strong odors. I had a patient, a nurse that worked with me, Christiana, that had asthma so bad that she would ask all of us, please don't wear any perfume or anything to work. Because any strong odor smell triggered her asthma. And of course to us, I'm like, it didn't seem strong to me, but anything like that was a trigger for her. So she was that sensitive to odors. Allergens, there it is. Allergic to dust, dogs, whatever you might be allergic to. Any kind of environmental exposure, any recent respiratory infections could be your trigger for asthma. Any of these things listed here, certainly smoking. Gastric reflux is one that we tend to forget. Why do you think gastric reflux could potentially be a trigger for asthma? What is happening when you have gastric reflux?
Everything is coming up here.
Right. So everything that's normally in your stomach that's very acidic, and you don't have control of that acid, or you're not taking your Nexium, or you're not taking your antacids, or you don't have your Tums, or whatever it is that treats your gastric reflux, Where does that acid potentially go to and inflame? And where's your trachea? Isn't it right next to your esophagus? Couldn't you potentially could come back up and now you could potentially aspirate some of that acid? You don't necessarily have to have an aspiration pneumonia, but it's a trigger because of the acid content of that reflux that's coming back up. So we tend to forget that. So don't forget about the gastric reflux. Your answer might be, is the patient taking their antacids if they have a history of gastric reflux? That's one of the things that we tell people, control your reflux, it will help control your asthma. Certainly anything in the air, certain food additives, right? If somebody's allergic to something or sensitive to something. So these are all of our triggers. There's lots of them. Everybody has different ones. What are we going to try to get the patient to do? Avoid the trigger, if you can, if at all possible. If you know that smoking is a trigger for you, and now you're going into someone's home that smokes, it's probably you're not gonna feel real well. So stress, cold air, emotions, exercise, any of those things, temperature change, all of these things are our triggers. And they're all listed here. I've explained that a little bit more. So what happens when somebody has asthma? Here's our alveoli that is open. We keep saying the same thing, but this is where your air exchange is happening. Look at the airway of somebody that's having an asthma attack. See how constricted that is? There's not a whole lot of air exchange happening. It's very tight, it's very narrow. A lot of air trapping happens. So rather than the gas exchange happening at that little alveoli that's all the way at the bottom part of our lung, all the air is trapped. And that's what happens with asthma, they have air trapping. The 3 most common symptoms: cough, difficulty breathing, and wheezing. There they are. That's what the asthma patient typically has. They might have chest tightness. Can they have a cough with or without mucus? Yes. Bronchitis, remember, is the one that has more of the thick mucus production. Asthma doesn't always have a lot of stuff that they cough up. It's more like a dry, non-productive cough that the patients have. It's annoying. It's the same cough I had. It's annoying. It annoys you guys. It annoys me. Right? And so again, it's this dry, non-productive, hacking cough that's annoying, but these are the symptoms that they have. And then there's that wheezing. So here's our medication. Short acting, this is what they're called. Beta 2, remember there's beta receptors in our lung and in our heart. They relax the smooth muscle, and there it is, albuterol. That's what we're gonna pick first. It's a beta 2 agonist drug, that's the category that it's in. Can we use this to relieve some acute symptoms? Yes, that's our acute treatment for asthma. Here's some other medications that are down here. Atrovent, anybody ever heard of that? So that's used for patients who do not tolerate these drugs. And what do I mean by not tolerating them? Well, maybe that patient that gets albuterol becomes extremely tachycardic, and they have palpitations, and they feel so shaky they can't take it anymore. What are our typical side effects once we get albuterol? What happens to the heart rate? Heart rate goes up. That's going to happen every time they get tachycardic. So if your patient that in the story just got albuterol, and now your rhythm strip is sinus tachycardia, right? Now that we know what that looks like, what are we going to do about it? Anything? Nothing really. If it's 110, 120, but they just got albuterol, what would we say about that? That would be kind of normal, kind of expected. Would I expect it to come back down to baseline within maybe 5 or 10 minutes? Yes. So just always remember, it's going to make the patient tachycardic. It's going to make them have some anxiety a little bit. It makes you a little restless. It makes you a little shaky. That's a side effect of albuterol. Well, go back to our ABCs. Isn't it more important that we open their airway and then they tolerate the side effects? That's what we're worried about. So albuterol is our first, so short-acting beta agonist is what we call it. The patient has an acute attack of asthma, we're going to use this. What do anticholinergics do? They counteract the bronchoconstriction. That's what's happening. The bronchoconstriction is what is that trapping. The bronchi are constricted. They're trapping the air in. They're not getting air exchange. That's why we hear wheezing when somebody has an asthma attack. So we can use Atrovent. Sometimes when, you know, I was working at the hospital, we would call and somebody would need a respiratory treatment, and respiratory would come around and they would give albuterol and Atrovent at the same time.
Yeah,
So they could get both of these meds together.
Yeah.
And now they both work in different ways. This one relaxes the smooth muscle. This one relaxes the bronchoconstriction. So basically, both things are gonna be what we need to make the patient breathe better. Long acting. Anybody in here on a long acting asthma medication? What does that mean? These are meds that are mostly help prevent attacks. So albuterol would not be a med that you're gonna pick to prevent asthma attacks. It's a med that we use right now. Atrovent right now. These meds, anybody heard of Singulair? What's the Flovent? What's the purple disc? Is Advair the purple one? Do you know what I mean? That purple thing that you dial?
Excuse me, Mrs. Anderson?
Yep.
They're here to pick me up to take me down now.
Oh, good luck, Celicia.
Thank you. So I will contact you as soon as I can.
Okay. Lord Jesus.
All right.
bless Celicia right now.
All right, thank you. Bye, guys.
Bye.
Bye, good luck.
I hope they're doing recovery. Okay, so here's our steroids. What does it do? Anti-inflammatory. So there are some respiratory medications that we can give as a nebulizer that are steroids. There are some that are not. If we're giving two things, one is a bronchodilator like albuterol, and another inhaler like cromulin sodium, that's another one that I've given, is a steroid. Which one do you think we would give first?
Albuterol. Yeah, bronchodilator.
The bronchodilator first. Why do you think?
Open the airway.
To open the airway.
Yeah.
So pick that. If there's a sequence of how I'm giving these treatments, I want to use the bronchodilator first. Makes sense, right? I want to open the airway so now the steroid can work. The steroid's not going to work if the airway still is trapped.
That's what the nurse
So-
said, because I used to, right?
Mhm.
Albuterol and Patrol PM or something like that. So she said always.
You always do the albuterol first, so pick that first. Now, if the patient is getting a inhaler that has a steroid in it, and they usually end in SONE, what do we tell the patient to do after they did the inhaler?
Wash their mouth out.
Wash their mouth out. Why?
Because it can create a fungal infection.
Yes.
Absolutely. Whoever said that at home, absolutely. Who was that?
Stephanie?
Stephanie. Good. Yes. What can happen? The steroid causes thrush in the mouth, potentially. Thrush is that yeast infection in the mouth. Oral candida is that yeast infection in their mouth. Remember that white patchy coating? So the steroid inhaler, when they use it, after they use it, we tell the patient to rinse their mouth out. Should they swallow it? No, spit it out. So rinse your mouth out a couple times. So when you go in there with this steroid inhaler, take a little cup of water with you and an extra cup for them to spit into. Now, do I have to do that every time with albuterol? No. But people start getting in the habit of whatever inhaler they're using. Some people do it whether it's a steroid or not a steroid, but really you have to do it for the steroids. Because of the steroid property, it actually breaks down the inside of the lining of the mouth. And because it does that, the patient is more likely to develop that thrush or yeast infection in the mouth. So always pick that as your option in real life when you're doing this and on NCLEX. If it's a steroid inhaler, rinse their mouth afterwards and spit it out. So this is another treatment modality, if you want to call it that, for asthma. Sometimes patients get albuterol and Atrovent. Sometimes they get albuterol and the steroid inhaler. Sometimes it's a combination. Many times it's a combination of different things. And then there's certain ones that we use that we call rescue inhalers. That's albuterol that we use right now when we're having an asthma attack. So what is asthma? Acute episode of airway obstruction characterized by hyperactivity to triggers that are in our environment. Brings about wheezing. We have some swelling in our airway, bronchoconstriction. That's what's happening. Again, this is our pathophysiology. I'm not an AP teacher, but we need to understand what is happening when someone has an allergic reaction, an allergy, something they're exposed to, something that triggers it. We have inflammation, edema, spasms of the bronchi, and we need to open up that airway, get rid of that edema, get rid of that inflammation, create an air exchange again. So here's our signs and symptoms. And we said shortness of breath, wheezing, they might have a cough. One thing about an asthma patient that I have seen on NCLEX, on an ATI, prolonged expiratory phase. What does that mean?
Breathing out.
What's expiration? When we breathe out. So what happens? They might breathe in quickly. That's what their body does for them. They typically, their exhalation, their expiration phase of breathing out is a little longer than it should be. So they have that, then they breathe in again real quick. Use of accessory muscles, there it is. Using their chest muscles, not working hard to breathe, tugging to breathe. They might be irritable. This might be your child that has hypoxia. They might get sweaty. There's that cough again. They might have anxiety. They might get diaphoresis again. They might have a weak pulse. And then again, if they're hypoxic enough, it might affect their change in level of consciousness. So here's our patient with asthma. What do they look like? Short of breath, wheezing, cough. The patient typically is working hard to breathe, using upper chest muscles. They're working and tugging in order to try to get air exchange in because that bronchi is constricted and collapsed. And there's no air exchange happening. They might get sweaty. They might feel anxious. If you ever had an asthma attack, wouldn't you feel anxious? Anybody that has an attack does, right? It's scary because you can't get air in. Prolonged inspiratory to expiratory ratio. That's one key thing I've seen ATI ask us. Your patient becomes tachycardic. Your blood pressure may go up. They might be anxious. They might be restless. They might be disoriented if they have hypoxia and they start having signs of changing level of consciousness. So again, you're trying to correct it before they get to that point. But certainly right in the beginning, most people that have asthma know kind of what that asthma attack is coming on. Sometimes yes, sometimes no, but they start to feel it. And if they have their inhaler, they're hopefully going to try to prevent it from getting to this point. Okay, and this is just saying the pathophysiology of what happens when the patient has an asthma attack. Here's our triggers. Just talk about them. Smoke, having an infection like bronchitis or a viral infection, exercise, stress, allergies, cold air, certain foods. Here's our complications, and I think we'll stop there. Okay, pneumonia. How can pneumonia be related to somebody having asthma? What happens if you have repeated asthma attacks? What's not happening? There's no air exchange. Doesn't air get trapped? Wouldn't you think fluid would also get trapped? Aren't we breathing in and out, and what we're breathing we can't really see, but there is a moist component to it, right? So air trapping is happening, but also fluid is accumulating. More likely to develop bacteria in their lungs that they're not getting rid of. What do we say our cilia in our nose does? What does coughing do for us, right? Gets rid of that bacteria that's there. So the patient that has this air trapping, particularly older adult patients with asthma, more likely to develop pneumonia. And there's the other complication, atelectasis. What is that? Collapsed lung, collapsed airways. Pneumothorax is the whole lung is collapsed, but atelectasis is basically partial collapse at the alveoli level. Not the whole lung being collapsed. You need to understand the difference. What happens is at the alveoli, they're collapsed, like that picture that I showed you earlier. So right there where there should be gas exchange, there's not. So these are a couple complications from asthma. So your asthma patient themselves can recover. They can get their breathing treatment. They can get their albuterol. They can open their airway. But here are some things that can happen with repeated attacks that happen and more likely to happen, particularly for older adult patients. Someone talking? So here's our patient with asthma. Is there a family history? Does it run genetically to have asthma? Yes. Yes, it can. Here's your patient. They have that cough that we talked about. Many times have some increased mucus production, shortness of breath, expiratory wheeze. We hear that more on expiration than inspiration most of the time. Prolonged inspiratory to expiratory rates, meaning typically you're breathing in and breathing out is about the same amount of time cycle. What happens with asthma? Shorter breaths in, but longer breaths out because your body is trying to get rid of the air that's trapped. CO2 retention, why? What happens? Why does somebody have increased CO2 retention? What does that mean?
Oxygen can't leave.
The carbon dioxide builds up, right? This is why your body wants to make that expiratory phase longer. What happens when we're breathing out? That's when we're getting rid of carbon dioxide. Does that make sense? So it builds up. So what do you expect their ABG to look like when you do a blood gas on them? The CO2 many times is above 45. What's normal? 35 to 45. What's not happening when they're trapping that air is they're not able to then breathe the air out. So our CO2 builds up for this patient. The CO2 building up is what makes the patient get confused, get irritable, along with the hypoxia, but the CO2 buildup does that. When somebody is in a, let's just say, we talked about carbon dioxide exposure before, right? Carbon monoxide, like being in a garage or something. What happens? They can't blow off CO2. They can't bring in oxygen. That's what kills them, is that they're only getting carbon monoxide and not able to blow off the carbon dioxide. So this is what happens with the asthma patient. They have air trapping. They have an expiratory wheeze. The CO2 builds up in their lungs, and their body is trying to get rid of it. So the expiration phase is longer because your body's telling you get rid of all the extra CO2 that might have built up. So here's here's the other things. Increased occurrence in males and frequent onset before the age of 12. Most of the time, most asthma patients have had some incidence of it in their childhood years. Now I say most of the time. It doesn't mean you can't develop asthma later, but most of the time you see it before that. So here's all of our things that basically we're going to see with this asthma patient. But what's the most important thing? Status asthmaticus. It's life-threatening. Symptoms do not respond to usual treatment. We're not waiting 30 minutes. That thing says 30 minutes, the patient will be dead. 5 minutes at the most. Am I getting some relief from this albuterol? Well, then can I do a second one? And if I don't think I'm getting any relief and my airway is not opening, what should I be telling the patient to do? 911. Because that's what status asthmaticus is. It's not responding to the treatment that we did for that patient. Anybody know what an MDI is?
The one that we inhale.
A metered dose inhaler. It's a device that basically the inhaled piece goes to your mouth, but there's a device in the middle that kind of, like the little things that when we squeeze the thing, that's in the form of a metered dose inhaler. It limits how much we're getting. We don't just squeeze that thing and get a full dose every single, an unending dose every single time. So a metered dose inhaler basically is self-administered, and basically that little chamber device controls how much of the medication the patient's getting. And we can show you what that looks like in the lab. But that's usually common.
Right? Yes.
It's what? It's usually used for kids.
Yeah.
Usually used for kids. The reason why we usually use it for kids, don't we want to know exactly how much they're getting of this albuterol? For adults, if we get a little more, a little less, it's typically okay. But again, go back to what we know about pediatric dosing. With that meter dose inhaler, we're 100% sure how much of this albuterol they're getting. So it's a device that's kind of attached to the albuterol or the atropine or whatever bronchodilator they're getting. It's like a spacer. Yep. Mhm. Yep.
What is the other name?
Spacer.
Spacer.
Yep.
Yeah,
Mhm.
spacer.
So here's some common asthma inhaled medications. Again, look at these single, typically these bronchodilators are your like rescue inhalers that you use right now. Here's that purple disc, you guys might see this out there. Anti-inflammatories. Look at the medication. What is it? What kind of med is it? Is it a steroid? How are they getting that? Could they be getting this and that? Yes, absolutely. They could be using this for prevention, or it's a combination med. Some meds, these have a bronchodilator and a steroid mixed together in the med. So would I tell the patient to rinse their mouth? Yes, it still has a steroid in it. So again, don't study this like, oh, she's gonna put a picture on the test. There's so many of them out there, there's no way you're gonna know all of them. But what you need to recognize, which one do I use first? Which ones are for right now for my acute attack? And then give me some examples of what I would use, like the ones down here, Advair, and the steroid medications that are more for prevention. Ceravent, this is the green one, I've used that before. So just look through the slide and try to recognize, and then if you have an asthma patient in clinical, or you know somebody that has asthma, you're gonna start recognizing these names of these meds. There's a combination, and these are used to control, right? To help prevent asthma attacks. So if the patient in your story is having an acute asthma attack right now, don't pick that. Because that's a preventative, it's not gonna do anything, right? I'm gonna pick the one that's gonna bronchodilate right now. And there's our status of markets. This is pretty long. All right, so we'll pick up there tomorrow. Or no, we'll be back with you tomorrow. We might not be here long. If we're at home on Zoom tomorrow, we'll pick up with this. Okay. Let's stop now so you guys can. I think we're going to start lab a little earlier. So Miss Denise and Cassandra are coming in at 11. If you guys want to, I don't know if we're going to get out early or not, though. It's not doing anything. Nothing out there. What's your, supposed to start at 1? So it's 10:10. I have to figure out somehow to send you this dynamic quiz because I got to get into API. Let me call them. All right, so you guys at home, I will be sending you a dynamic quiz one way or the other. I'll call ATI again. For some reason, I was kind of.
It looks different.
Yeah, it do.
They did, because I couldn't find.
Does it-
didn't have like that zone there now.
Really? So I'll have to call them back because maybe that's why it's affected mine too.
It looks nice, but it's a.
They changed the whole ATI thing?
Yeah, you
No,
got
they like that. There was like 3.0 and there's 3.0.
Uh-huh.
They switched to 2.0 out, now we're using 3.0.
Oh, really?
Yes, it looks nice.
I wonder if that's why I couldn't like get to
You
this.
need to update.
I'm
gonna have to call. I'm gonna have to call. So I will call them and be able to send you a dynamic quiz. You have the respiratory packets in Schoology to work on. Our respiratory exam won't be until when we get back. Your ATI grid is due this Friday. So one way or the other, if you're in here on Friday, get it to me. You guys will be at clinical. So bring it to me Monday, right? But it should be done, definitely done by then. We don't have clinical, what's today? What's Tuesday? It's today. Wednesday. Oh my gosh, I'm losing track of my days. All right, so we should have clinical tomorrow for group 1 and 2, but I don't know. Look for your message on Remind. You might get an emergency message. I don't know what's gonna happen. I don't know if we're gonna get snow, sleet, ice. It's gonna all rain and wash it away. Who knows? So just plan on being here unless you hear otherwise. You guys plan on going to clinical unless you hear otherwise. Okay, and hopefully, I mean, if it is bad, we'll make a decision and probably do Zoom and everybody will just be on that. We'll keep on going. So why don't we today, it's 10:15. Are we okay? Let's just take our break now, maybe be back by 11:15 and then be ready to go in the lab. And so then we might get out a little early if the snow starts. I just want us to get our lab time and get it done. And then that way, if we leave, we can leave.
What are you doing in lab today?
So you guys that were at clinical last week, what are we doing in lab today? We did intradermal injections, we did sub-Q. Cassandra did a lot of scenarios with the sim mannequin and had you guys like actually talking and answering questions and taking care of the patient. So she's coming in. Have you guys done?
We did IM.
You did IM already?
Yeah.
Pulling them up and stuff. Have you actually practiced doing IM?
And we got signal.
Okay. What about dosage based, weight-based calculations.
We haven't
No,
done
no,
that
So we
yet.
need to work on that. Okay, like milligrams to kilograms and based off of the weight of the patient, how much would you give that? So we can work on that too. Somebody else have a question?
Yeah, what about this 3 for tomorrow? I tried it.
3 and 4 will be here in the morning, 5 and 6 in the afternoon, and then we'll switch on Friday. So I'll send out a schedule. Okay. I'm really, really hoping that when January comes, we can kind of all get out to clinical. And if they say yes, again, we might just all go out for 3 weeks. I don't know, just to get our hours in it. But we'll see how it goes. We are here through next Wednesday, which is the 23rd.
Anderson, or 3 weeks and the quotes next Wednesday or this weekend.
You're gonna be at Cook's this Thursday and Friday. I don't know if we'll go next Wednesday or not. Cause I feel like then we all gotta go get COVID tested for one day.
Right.
Yeah, like we need to get COVID tested today.
Yeah. So we might not go next Wednesday, cause it's one day and I feel like it's like a lot of work for one day. You know?
I could have guessed that. I didn't know.
Might be best for us to just be back in, here next week.
Yeah.
Yeah, I think that's what we should do. All right, everybody good?
Yeah.
So we'll be back by 11:15. Cassandra and Denise will be coming in and we'll try to start early in case the snow starts and then I can go downstairs and can we leave early? Maybe okay, everybody good? Sorry about my rant and rave, but we gotta all figure this out, okay? Hopefully that, from here on out, we'll be good.